The benign disorders of the liver. Today we'll be talking about cirrhosis of liver or chronic liver disease. Continue, Praveen.
Yeah, yes, sir. Good evening to everyone. Today we'll be seeing topic of chronic liver disease. It can be defined as a progressive deterioration of liver functions for more than 6 months, which includes the synthesis of clotting factors, proteins, and detoxification of harmful products of metabolism and excretion of bile. And this is a continuous process of inflammation, destruction, and regeneration of liver parenchyma, which ultimately leads to fibrosis and at last cirrhosis. So the common etiologies are alcoholic liver disease, non-alcoholic fatty liver disease, chronic viral hepatitis. And in chronic viral hepatitis, the most common causes are hepatitis B, C, and D infections. This chronic hepatitis C, if not treated, can lead to hepatocellular carcinoma also. We'll be seeing individually. Alcoholic liver disease has three histological types. First one is alcoholic fatty liver or steatosis, in which the fat gets accumulated under the liver parenchyma. And if this process continues, there will be inflammation in the liver cells, which based on the damage can cause hepatitis. And if this stage progresses, then it will be an irreversible damage to liver, leading to cirrhosis. And the daily consumption of around 30 to 50 grams of alcohol for over 5 years can cause this alcoholic liver disease. And steatosis occurs in 90% of patients who drink more than 60 grams per day, and cirrhosis occurs in 30% of individuals with long-standing consumption of more than 40 grams per day. So, at-risk drinking definitions for men is around over 14 drinks per week or more than 4 drinks per occasion. And for women and those greater than 65 years, over 7 drinks per week or greater than 3 drinks per occasion. And according to CDC, the one alcohol drink is equivalent to this criteria. So coming to pathophysiology, on consumption of alcohol under alcohol dehydrogenase enzyme, it converts into acetaldehyde. From acetaldehyde, it gets converted to acetate by aldehyde dehydrogenase. During this metabolism, the byproducts are NADH and glycerol phosphate. This glycerol phosphate combines with fatty acids and forms the triglycerides. And when due to deterioration of liver function and stoppage of metabolism of fatty acids, this triglycerides accumulate into the liver and causes the first stage, that is fatty liver disease or hepatitis steatosis. And on prolonged duration of time, due to the action of interleukins, there will be inflammation in the liver cells attacking the hepatocytes, causing the alcoholic hepatitis. So it can be evaluated. Sir?
Praveen,
Yes, sir.
can you tell us about the concept of fast and slow acetylators? According to this pathophysiology,
Yes, sir.
so there are people who drink a lot and do not, have any alcoholic liver damage or cirrhosis, and then there are people who drink not so much, but then develop liver damage and cirrhosis. And then there are people who drink quite a lot and still develop cirrhosis. So there are, lots of, permutations and combinations. So what has that got to do with pathophysiology?
Sir, in fast acetylators, this activity of alcohol dehydrogenase will be more, sir. So the byproducts will be more and the changes will be rapid in those people, sir.
Are you sure?
Yes, sir,
Anybody else? Anybody else knows about it? Nikita?
No, sir. I thought what Praveen said was the mechanism, sir.
No, don't think. You should either know it or you don't know it. Nitya and Sanya?
No, sir, I don't know, sir.
Okay, I think you need to look at it because it has a significant bearing on whether somebody develops cirrhosis or not. So, Praveen, check up.
Yes,
Okay,
Yes, sir.
carry on.
In previous ones, I saw fast accelerators, they have 6 times faster metabolic activity, sir. So that's why all these changes will be rapid in those people. Slow accelerators, it will be comparatively slow, sir.
So fast
Once again, I'll
accelerators,
check it, sir.
fast accelerators will develop cirrhosis, more likely to develop cirrhosis compared to slow accelerators. Is that what you're saying?
Yes, sir. Yes, sir.
Okay, so check that up and
I'll
confirm
check
that.
once again,
Okay,
sir. Yes, sir.
put it in this one group. Okay,
Okay, sir.
okay.
And the evaluation is by routine complete blood count, LFTs. In LFT, AST will be markedly higher than ALT, which is more pronounced in alcoholic hepatitis. And protein prothrombin time INR, acetic fluid, serum acetyl-albumin gradient. This serum acetyl-albumin gradient, based on the value, we can differentiate whether it is due to portal hypertension or peritoneal causes. If it is high, that is greater than 1.1 grams per deciliter, then the cause is mostly of portal hypertension. If it is low, that is less than 1.1 grams per deciliter, then it will be of mostly of peritoneal causes such as tuberculous peritonitis or secondary peritoneal carcinomatosis or parasitic infections.
So you just repeat that again. Say what is acetic fluid? What you say
Sir,
the age?
serum ascites albumin gradient, sir. If it is low, then it will be of peritoneal causes. If it is high, then it will be of portal hypertension causes, sir.
Okay, right.
Then screening blood test checkup to rule out either viral hepatitis causes, and endoscopy to look for esophageal varices due to portal hypertension causes. So the treatment will be of alcohol abstinence.
No, go back. Go wait.
Sir, yes, sir.
Go
Yes,
back. So gamma GT, you should stress that gamma GT will be high in patients with alcoholic liver disease.
yes, sir.
And then you have to talk about where is ultrasound and all that. You have come to evaluation now, you have already gone to treatment. Where is ultrasound? What are the things in ultrasound? Do you need to do anything else? CT, MR?
Praveen, you're talking about that fibro scan and all those things, ultrasound and all later, or how?
Sir, in the later part, sir. Evaluation
No,
of
Later
but
part you're
CLD.
talking.
here, no, but you said you have put as evaluation. So I thought all that will come here. Okay, if you are going to talk about it later, fine. Carry on.
Sir.
See, what you should have done was, you should talk about the pathophysiology of alcoholic liver disease, pathophysiology of hepatitis, and then go for evaluation, then go for treatment.
That
Now you are
that is what that is what I told you, no, Praveen. You put that, otherwise there will be a lot of confusion because you have to move from here, there, and this one. So you should have, as sir suggested, that is how it should have been. Like the causes for CLD, evaluation, that pathophysiology, how they cause, and then evaluation of CLD,
Yes,
and
sir.
then treatment. You have put it up. But
Yes, sir, in
then
the
why you are
same way,
telling
but
investigations now?
sir, this is specific to alcoholic hepatitis, sir.
No, you are not going to do, for alcoholic liver disease, you are not going to do ultrasound, MR, or fibroscan or anything.
Required,
Is that
sir.
what you are saying? Huh?
No, sir, it's required.
Then you said it is specific for alcoholic liver disease, no? And you have not put any of those things up here. You have put endoscopy, but you have not put up any scans. Why is it important? Okay, anyway, do whatever you are doing. Let us see. Can't change it now. See, that is why you guys have to listen to the teachers, because when we say something, there is a reason for it. Okay, carry on.
Yes, sir. So the treatment will be of alcohol abstinence and enrollment to detoxification programs, nutrition support due to malnutrition, and screening for hepatocellular carcinoma at the USG every 6 months, and screening for esophageal varices. And as chronic alcoholics are more prone to develop hepatotoxicity, so acetophen dose should not exceed more than 2000 milligrams per day, and normal individuals is 4000 milligrams per day. And to treat if any coexisting liver diseases such as hepatitis B and C viral infections if present.
Now, how does alcoholic abstinence help? What will it do? Is it effective?
It reduces the byproducts, sir.
See, if cirrhosis is already set in and portal hypertension is already there, abstinence from alcohol, will it help or is it
No, sir. It's in initial steatohepatitis
stage?
patients. Yes, sir.
Once cirrhosis has developed, it is difficult. One is practically it is impossible for people to stop drinking at that stage. And even if they stop drinking at that stage, I don't know if there, I think there is very little evidence to suggest that the progression of the cirrhosis to end stage liver disease and portal hypertension and its complications and progression to hepatocellular carcinoma, all these things cannot probably be reversed, even if you abstinence from alcohol. But if you stay away from alcohol at the stage of early fatty liver and alcoholic hepatitis stage, maybe then we can avoid getting into the cycle of cirrhosis.
Yes, sir.
Niranjan?
Yes, sir.
Okay,
I agree.
carry on.
Yeah, carry on.
So coming to non-alcoholic fatty liver disease, which is the next common cause, it is a spectrum of conditions which is characterized by hepatic steatosis and imaging or histology, and there is absence of secondary cause of hepatic steatosis. So it starts with simple steatosis, followed by steatohepatosis, fibrosis, cirrhosis, and which can lead to hepatocellular carcinoma. Usually it is associated with obesity, diabetes, dyslipidemias, insulin resistance, and metabolic syndrome. It is seen in around 80% to 90% in obese adults, 30% to 50% in patients with diabetes mellitus, and 90% or more in patients with hyperlipidemia. Usually the proposed pathogens is two-hit model. First, it will be of due to insulin resistance, which leads to free fatty acid and triglycerides accumulation. Second, it is due to paroxysmal fatty acid oxidation and formation of reactive oxygen species from this above metabolism. And due to obesity, there will be hepatocellular injury following the NASH. So the evaluation will be by aminotransferases. The AST to alanine ratio will be less than 1 in NASH, and there will be increased GGT value. Ultrasound is done for evaluation of this NASH. Liver biopsy is a proposed gold standard method for diagnosis of NASH. And these are the clinical predictors used to grade the severity of NASH. This is NAFLD-MS score, which has 5 criteria: BMI, AST, ALT ratio, type 2, whether patient have type 2 diabetes mellitus or central obesity. This is the most common score used, and others are NAFLD fibrosis score, fibrosis 4 index, original enhanced liver fibrosis test, and AST to platelet ratio index. So management will be of lifestyle changes and proposed weight loss of around 3 to 5% in simple steatosis. And if patient has already developed NASH, then weight loss of around 7% to 10% is recommended. And adequate control of risk factors for hyperlipidemia should be with statins, and adequate glycemic control is required. If NASH with cirrhosis as alcoholic hepatitis, they also required surveillance for hepatocellular carcinoma with ultrasound every 6 months. So coming to other causes of CLD.
Wait, what are the modern treatments for? See, because of course we will send it to the gastroenterologist to manage it. but we still have to know. Just like if you're asked about chemotherapy for breast cancer, it's not that we are giving it, but in the exams they will ask you what are the common regimen for CA breast. Similarly, the patient may also ask you what is the treatment for because NASH is a very NASH and NAFLD is very common. Every ultrasound scan will say there is fatty liver. So patients are worried and they'll come to you. So what will you do? What is the current management of NAFLD and NASH apart from what you have suggested? Did you look into that?
Yes, sir. These
What
are
is the
the
treatment?
most common reactions.
Huh?
Uh,
There are new
in
treatments available. You should have gone and spoken to Dr. Vijay Kumar or Dr. Purna Chandra or even our what's his name? The new junior consultant. If you had spoken to them, you would have known. There are new treatments available for for this one for fatty liver disease. When are you going to talk about the fibroscan and everything? It's all a mishmash, man. You should target. It should be a smooth flow. Okay, carry on. We can't do anything now. Can't change this order of your slides. Carry on. I think all of you go and see. I think this is the what I feel that there is no there's lack of interest amongst you guys. See, I think fatty liver disease is a very common thing. When you are consultant with the exam, the patient comes to you with an ultrasound scan and asks you about fatty liver disease, it will make good sense because people will be impressed if you can tell them what it is, what should you do, what are the treatment. You may refer them to a gastroenterologist, but it is important for you to know it also as well. So you should go and talk to Dr. Purna Chandra or Dr. Vijay Kumar.
yes, sir.
Okay.
Yes, sir.
Okay. There are new treatments available now. Okay.
Uh, Other causes of CLD can be of genetic causes, that is alpha 1 antitrypsin deficiency, which is the most common among children. Hereditary hemochromatosis, which is an autosomal recessive disorder, and Wilson disease. And there can be a autoimmune causes such as primary biliary cirrhosis, which involves destruction of intrahepatic biliary channels and portal inflammation resulting in scarring, which results in cholestatic jaundice and fibrosis, and it is most commonly seen in middle-aged women, and usually alkaline phosphatase levels are increased in this biliary cirrhosis.
So,
And
Praveen,
yes,
if
sir.
it is an autosomal recessive condition,
Yes, sir.
what percentage of people will be affected? If you say it's an autosomal recessive disorder, how many children? If, for example, the couple have 2 children, how many
One children will be
affected?
affected, sir.
Huh?
One children will be affected, sir.
So 50% penetration.
25%, sir.
Autosomal
If
recessive is 50%. For
Sir,
autosomal dominant is 25%.
sir,
Generally.
no, sir. Autosomal recessive is 25%, sir. 1 out of 4 children will get it, sir. Autosomal dominant, 2 out of 4 children, sir, will be affected.
I think you need to check, or even I need to check that. I think the autosomal recessive has more penetration. Anyway, check that. We'll check that. Is anybody more knowledgeable?
I think I also have to check now. Probably we'll check.
Nikita, are you any more knowledgeable about recessive and dominant?
Sir, I'm
Sir,
sure that 25% is for the recessive, sir.
Uh,
Chances of both being recessive autosomal genes is 25%, sir.
because it requires both the recessive trait to come into so that it can there can be manifestations, sir. But for autosomal dominant, it is heterozygous, sir. For
Analysis.
autosomal recessive, it is homozygous, sir. Both the recessive allele has to be there to for that genetic expression, sir. So it is 1 in 4 children for
For
autosomal
recessive
recessive, sir.
and for
Yes,
dominant,
sir.
1 in 2. Okay, fine. I think that makes sense. Okay.
And other causes are
Carry on.
yes, sir. And other causes are primary sclerosing cholangitis, which is commonly associated with ulcerative colitis, in which there is decrease in size of intrahepatic and extrahepatic bile ducts due to continuous inflammation and fibrosis. And other causes are autoimmune hepatitis, which is chronic inflammatory hepatitis, more commonly seen in women. Here there will be increased antibodies of anti-nuclear antibodies, anti-smooth muscle antibodies, and hypergammaglobulinemia. And other causes of chronic liver disease includes drug-induced CLD, which are caused by amiodarone, isoniazid, methotrexate, phenytoin, nitrophenolate most commonly. And vascular causes include Budd-Chiari syndrome. This Budd-Chiari syndrome is characterized by obstruction of hepatic venous outflow. This can be of thrombotic or non-thrombotic, and it can be anywhere from hepatic venules to junction of inferior vena cava. It is primary Budd-Chiari syndrome if there is endoluminous venous lesion like thrombosis, and it is secondary if there is external compression or due to tumor. It can be due to hereditary or acquired hypercoagulable state conditions such as antithrombin 3, protein C, or proteinase deficiency, which is seen in around 75% of patients. And primary myeloproliferative disease is the most common cause for hepatic vein thrombosis, which is seen in 20% of cases. And consumption of OCP is also a risk factor for Budd-Chiari syndrome. Here, the pathogens is when there is blockage of 2 or more major hepatic veins, there will be increased sinusoidal pressure, which causes reducing in sinusoidal blood flow. This causes sinusoidal dilatation and infiltration of interstitial fluid. This fluid passes through the liver capsule, causing the congestion, and there will be ultimately right upper quadrant pain and ascites. And further, the portal pressure will be increasing and perfusion of liver via the portal vein will be decreased. And there will be non-inflammatory central lobular necrosis in around 70% of cases. And few weeks after this obstruction, slowly fibrosis develops around the central lobular area. And after a few months, there will be nodular regeneration around this periportal area. And this caudate lobe undergoes compensatory hypertrophy and further causes IV stenosis. So it is can be diagnosed only under these conditions if there is any abrupt onset of ascites and there is painful hepatomegaly, or massive ascites with relatively preserved liver function, sinusoidal dilation in liver biopsy without heart disease, fulminant hepatic failure associated with hepatomegaly and ascites, or there is unexplained chronic liver disease or liver disease with thrombogenic disorder, and if serum transferase levels is more than 5 times than the normal range, or if serum alkaline phosphatase and bilirubin levels increase and serum albumin level decreases moderately. In all these conditions, if it is said, then we can suspect diagnosis of Budd-Chiari syndrome. And Doppler ultrasonography is most sensitive and specificity for initial investigation. Here you can see hepatic veins without flow signal, and there will be spiderweb appearance along with collateral hepatic venous circulation due to the stenosis and formation of collaterals. And MRI will be the second line imaging, which shows hepatic vein thrombosis. And also it helps to evaluate the inferior vena cava. Management will be of liver transplantation if it is under final stage of fulminant liver failure or if there is cirrhosis. If the liver parenchyma is relatively normal, then we can do the intrahepatic portosystemic shunt or site-to-site portocaval shunt. And we can relieve compression of IVC by retrohepatic expandable metallic stent also. And these patients, as they are more prone to deficiency in such as antithrombin 3 protein C or proteinase deficiency, they require lifelong anticoagulation therapy. So, as we have seen the causes, we'll be seeing the pathophysiology of CLD. Here, this is a continuous process of hepatic fibrosis and which results in distortion of liver parenchyma and formation of regeneration nodule formation. The endpoint will be of either irreversible fibrosis or regeneration of nodule formation or development of cirrhosis. This process will be rapid if there is co-infection with HIV or HCV, and this is slowest with primary biliary cirrhosis. Here, the hepatic stellate cells will get activated into proliferative fibrogenic myofibroblast, which will increases the expression of inflammatory receptors of ICAM1 and other inflammatory mediators. These mediators causes accumulation of extracellular matrix and causes progressive fibrosis. Clinical manifestation of CL will be of mostly non-specific, that is fatigue, anorexia, weight loss, and due to particular complications, they may present with esophageal varices or ascites, jaundice, hepatic encephalopathy. Coming to the portal hypertension, which is a most common complication and symptom is present. It occurs due to resistance of portal blood flow because of cirrhotic or non-cirrhotic etiology. Usually, the portal pressure will be of less than or equal to 5 mm of Hg. If it is between 5 to 9 mm of Hg, it reflects that there is subclinical disease. And if it is greater than 12 mm Hg only, the clinical features or complications will develop. And etiology of portal hypertension can be classified as prehepatic, intrahepatic, and posthepatic. Prehepatic, most common cause will be of portal vein or splenic venic thrombosis or external compression due to tumor. Intrahepatic can be classified into pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal may be of due to schistosomiasis, congenital hepatic fibrosis, primary biliary cholangitis, sarcoidosis, toxins. Sinusoidal will be of due to cirrhosis, alcoholic hepatitis, vitamin A intoxication, and cytotoxic drugs. Post-sinusoidal may be due to sinusoidal obstruction syndrome or veno-occlusive disease, that is Buchiari syndrome. And post-hepatic may be of due to Buchiari syndrome, veno-occlusive disease, and congestive cardiac failure. So the most common feature will be of hematemesis from the bleeding varices, and there may be of there will be of symptoms of sigmoid of cirrhosis, that is spider telangiectasia, palmar erythema, gynecomastia, testicular atrophy, jaundice, ascites, and curvilier Baumgarten syndrome, which is due to dilated abdominal veins, and there will be low venous murmur at umbilicus. And due to hypersplenism, there may be anemia along with pancytopenia. And these are the common varices formation. Esophageal varices will be due to the varices between esophageal branch of left gastric vein along with esophageal branch of esophagus vein. And rectal varices will be due to varices between superior rectal vein and middle and inferior rectal veins. Caput medullae at paraumbilical level will be due to paraumbilical veins and superior epigastric veins. And these are the less common varices found below in the retroperitoneal area and intrahepatic areas. And portal hypertension can lead to thrombocytopenia due to congestive hepatopathy, abdominal collaterals, variceal bleeding, iron deficiency anemia due to splenomegaly, ascites, which can lead to spontaneous bacterial peritonitis, hepatic hydrothorax, hepatorenal syndrome, hepatic encephalopathy, hepatopulmonary syndrome, portopulmonary hypertension, and atlas cirrhotic cardiomyopathy. So endoscopy is the mainstay of diagnosis. In endoscopic, we'll be looking for esophageal varices, gastric varices, and portal hypertensive gastropathy. And vascular imaging will be done. It can be done with ultrasonography or with angiography. Angiography is the proposed gold standard for knowing the portal venous anatomy and pressure measurements. And hepatic venous pressure gradient is known by it is the difference between occluded and free hepatic veins pressure. It helps in staging of the portal hypertension. And other method is direct portography. Here we'll be catheterizing the portal veins, which helps us in knowing the direct pressure measurement. And for the complication of variceal bleeding, usually we'll start with pharmacotherapy by vasopressin and stomatostatin. Vasopressin will be giving infusion at 0.2 to 0.4 units per minute along with nitroglycerin, which is effective in around 80% of patients. We can use the long-acting analog of vasopressin of glypressin, and we can use the stomatostatin, which is other long-acting analog is activated by infusion of 50 mg per hour. And other modalities are endoscopic band ligation, and decompression of varices can be done by surgical or radiological shunt. In radiological shunt, the most common used one is transjugular intrahepatic portal systemic shunt. It has around 92 to 90%, 99% of success rate. The absolute contraindication is if patient had right-sided heart failure or severe liver failure and polycystic liver disease. Related contraindications will be of hepatic tumors, encephalopathy, and hepatic or portal vein thrombosis. And the complication due to stent may be due to acute stent thrombosis or hemophilia due to stent migration. Here, the major issues will be of encephalopathy, which can be seen around 20 to 30% increase. Surgically, we can decompress by total or partial portal systemic shunts. In total portal systemic shunt, we'll be doing end-to-side shunt, where portal vein is divided at bifurcation and proximal end will be anastomosed with inferior vena cava. Or we can do by side-to-side anastomosis by portal vein or a tributary of inferior vena cava greater than 10 mm in diameter along with inferior vena cava. Here by this portal flow is diverted, but this may result in partial hepatocellular dysfunction and encephalopathy also. Partial portal systemic shunt will be done by portogaval graft of 8 mm in diameter. Here, the portal pressure will be reduced to 12 mm of Hg and flow can be maintained partially in around 83% of patients. There is other method of selective shunt, which is distal splenorenal shunt. Here, it can be used for decompression of esophageal and gastric varices by connecting splenic vein into left renal vein. By these shunts, around bleeding is controlled in 90% of patients, but the negative thing is the formation of increase in cases of encephalopathy. In distal splenorenal shunts, there is around 10 to 15% increase in encephalopathy rates. In partial stents, it's around 10 to 20%. In total shunts, it's highest around 30 to 40% of increase in encephalopathy chances.
Praveen,
Yes, sir.
no, you mentioned everything, but you didn't tell us when will you do what? When will you do tips? When will you do like surgical procedure of devascularization when there is bleeding? When will you do shunt?
Sir, initially by medical management, sir, if medical management did not resolve,
No, what
then
do you
we'll
mean
be
by
going
medical
to-
management?
Sir, this one by pharmacotherapy and endoscopic therapy, sir.
No. Like this is for portal hypertension you're talking about, right?
Yes, sir, variceal bleeding. Yes, sir.
Variceal bleeding. But if you do tips, like how do you differentiate when will you do tips and when will you do shunt? Sir?
I think, see, Praveen, what you should mention is that majority of surgical procedures are now confined to
Almost
the
given up,
pages of
probably shunts.
history. Only operation which you may consider doing is if, for example, you are unable to control the bleeding even with sclerotherapy, which is very, or with banding and tips, which is very rare. And if that happens, then you do what is called as esophageal devascularization.
Figuras procedure.
Seguras procedure, but very rare. But all other shunt procedures now tips is tips is the only procedure that is done radiologically, and it is equivalent to your partial shunt. So that is the only procedure done. The others are all mentioned now, but I think majority of surgeons have given up doing. It is because one, it is a long procedure, and I think the morbidity and mortality is, I think, 5 to 10% mortality,
And also chances of encephalopathy, I think, is higher.
For distal splenorenal shunt, the encephalopathy is less, but for portocaval shunts, the encephalopathy risk is very high. So
Yes.
generally, and you can do other thing is the Nakamichi, I think is one of the left gas coronary vein to portal vein that can be done. And again, the risk of angiophlopathy is less, but most of the shunt procedures are given up now. I think it is either endoscopic and medical management sclerotherapy, and if that fails or if it is recurrent, then you do a TIPS procedure to reduce the portal venous pressure. So you should be very clear. All these mentioning all these things is fine, but you should, as Niranjan said, you should know when to do what.
Yes.
So, sir told that is what. So, most of the times will be either endoscopic therapy. You stabilize the patient. Then, once the patient is stable enough, you send it for if there is like if there is recurrent bleeding and all, send them for tips. But again, after you do tips, probably you have to consider the patient for liver transplantation. Once you do tips, I think, sir, one year, Allah, they
Ah,
can manage with tips.
ah.
You have to within 1 year they have to consider liver transplantation.
Okay.
Okay, go
Carry
on.
on.
And in cases where surgical shunt is not possible, then we can do the devascular procedures as mentioned. And liver transplantation will be done for end-stage liver disease. Coming to ascites, which is the next complication of CLD, it is accumulation of fluid
Praveen,
in
again, liver transplantation is not like end stage liver disease means what end stage? Like, again, you have to clarify there. If it is totally gone, even that those candidates may not be fit for liver transplantation also.
So you have to mention the MELD score, MELD sodium, what is that? The new one.
Delpux score and ML scores.
Yeah,
And
Yes, sir.
then
It is yes, sir, next.
child
Child
pube.
pube.
Yes, sir.
Okay.
Child pukes.
Okay, and one more thing is it is not mandatory for you to do tips always and then go for liver transplantation. If patient is fit enough and if you control the bleeding through endovascular therapy and there is no active bleeding, still patient can be taken up for directly liver transplantation. It is not mandatory that you have to go through the tips route always.
Okay, sir.
Okay, yeah.
Yes, sir. And, the next common complication of CLD is ascites. It is accumulation of fluid in peritoneal cavity, and it occurs due to raised portal pressure, that is due to increased hydrostatic pressure, decreased albumin due to decreasing liver functions, which causes reduced oncotic pressure, and due to splanchnic vasodilation due to release of nitric oxide. The management will be of sodium intake restriction to 2 grams per day and spironolactone and furosemide as diuretics to reduce fluid overload, and paracentesis followed by tips. The next common complication is hepatic encephalopathy, and it can be graded into 0 to 4. 0 if there is subclinical or normal mental status. 1 if there is lack of awareness or anxiety or impairment of altered sleep rhythm. 2 if patient are lethargy or disoriented to time or there is inappropriate behavior with asterixis. 3 if patient is confused with gross disorientation and there is bizarre behavior, and if patient is in coma, then it is graded 4. The usual treatment is to reduce the precipitating factors by giving rifaximin and lactulose, and liver transplant is the only curative treatment. And next complication will be of hepatorenal syndrome. This is usually the diagnosis of exclusion, and it occurs due to the vasoconstrictors which are seen in CLD, which results in narrowing of vessels. And the usual criteria is when there is chronic liver disease with portal hypertension or advanced liver failure, and there is continuous rising in creatinine, that is usually more than 0.3 milligrams per DL within 48 hours, or doubling from baseline within 7 days. Oliguria along with absence or minimal proteinuria, or urine sodium less than 10 milliequivalents per liter. If all these conditions are met, then it can be diagnosed as hepatorenal syndrome. And along with this, there will be failure to improve with volume expansion, and after the stopping of diuretics also, there will be absence of shock, and there will with no recent use of nephrotoxic drug, and absence of any renal parenchymal disease. Usually, hepatorenal syndrome is of two types. In type 1, there will be a rapid and progressive decrease in renal function. There will be doubling of serum creatinine at least greater than 2.5, and urine output will be less than 500 ml per day. Type 2 will be of less severe kidney injury, and it is usually due to diuretic resistant ascites. And type 1 is more severe when compared to type 2. The treatment will be of norepinephrine or telpipressine with albumin infusion, or it can be done with octreotide with albumin infusion. The only definitive treatment will be of liver transplantation. And coming to assess the severity of chronic liver disease, we'll be using mainly the two scores, that is child score, which has components of ascites, bilirubin, albumin, prothrombin, and encephalopathy. And if score is 5 to 6, it will be of class A, that is well compensated disease. Score of 79 will be of class B with functional compromise. And score of 10 to 15 will be of class C, that is decompensated disease. And the new staging disease is model of end-stage liver disease, that is MEL score. It uses the bilirubin, serum creatinine, and INR. MEL score was initially used for prediction of mortality within 3 months after TIPS procedure, but it is now used to grade and prioritize the patients for liver transplantation. And the final stage.
What is the modification of MELD, man? They added sodium with that, no? You don't know about that?
Yes, sir.
Yes, sir. Serum sodium is added. Yes, sir.
Okay.
So the final stage of CLD will be of cirrhosis. That is, it is characterized by fibrosis and nodule formation of liver. It can be due to secondary chronic injury. And the common etiologies, as explained to CLD, it will be the same of hepatitis B, C, D virus, alcoholic liver disease, NASH, primary biliary cholangitis, primary sclerosing cholangitis, hemochromatosis, Wilson's disease, Bucharest syndrome, drug-induced liver cirrhosis, or it can be due to chronic right-sided heart failure. Morphologically, it can be classified into micronodular, and mixed cirrhosis. In micronodular, there will be nodules less than 3 mm in diameter, and most common causes are alcohol-induced hemochromatosis, chronic biliary obstruction, and due to cirrhosis. In macronodular cirrhosis, it will be of irregular nodules greater than 3 mm in size, and most common causes will be of due to hepatitis B and C, alpha-1 antitrypsin deficiency, and primary biliary cholangitis. Mixed cirrhosis, there will be of both micronodular, micro and macro aspects. Here, the micronodular cirrhosis will be progressing into macronodular cirrhosis over time. Based on etiology, it can be classified with as viral, toxin, autoimmune, due to cholestatic, vascular, or metabolic causes. And management will be as the damage to liver is permanent. Only we can stop the progression of the disease by giving specific therapy for the targeted etiology. As mentioned, for viral hepatitis, antiviral medications and steroids and immunosuppressive agents for autoimmune hepatitis. For primary biliary cholangitis, use of ursodeoxycholic acid. In Wilson's disease, copper chelation. And in hemochromatosis, iron chelation and phlebotomy. And in NASH with weight loss, and in alcoholic cirrhosis, it can be done by alcoholic abstinence.
You said you are going to talk about radiology. You never said anything about radiology. What is the role of ultrasound? What is the role of fibroscan? What is the role of MR liver, CT liver?
So it should have been better, Praveen, if you had just mentioned the causes, pathophysiology, and in broad this thing, how you relate a case of CLD. If patient comes, they don't come like separately like alcoholic or separately like viral or whatever. So you should have put a broad outline. What is the role of blood test? What is the role of other investigations? And then you could have told individual treatment if there was any separate treatment. Ultimately, most of them will land up with liver transplantation if they go into end stage liver disease.
See, this class, Praveen,
Yes,
it
sir.
is not sufficient for undergraduates. Forget about postgraduates. I think you didn't say about MELD score. What is the significance of MELD score? At what score do you recommend transplantation? And then what is the Rome criteria for transplantation in tumors? Of course, that
Sir,
comes in.
liver transplantation separate classes, sir. That's why I did not
I
mention.
know,
No,
but still,
but you have to tell us when will you consider liver transplantation in a simpler way. Like we don't want that entire thing. Liver transplantation, I know, is a separate class. But here, when you're talking about liver transplantation, if you will tell what category they fall into, and then we will consider liver transplantation.
see
If you
okay. Let us just accuse your see what Ainas, are you there?
Yes, sir.
Ainas, tell us what are the
Yes,
ultrasound features of liver disease? What are the things that I will
sir.
talk
Like,
about?
so the in ultrasound, you'll so it will tell about how the if there's atrophy or hypertrophy, like it will tell about that the nodularity, if there is like the echogenicity, and if it is appearing irregular, sir, that will be consistent with cirrhosis, sir, and that will be seen in hepatic steatosis also. And in addition, it can also tell about the size, sir, like
Is there
but the sensitivity will be relatively poor in ultrasound. Sir,
I think you're
like this is
just
what, sir, you will
searching.
see like in ultrasound.
You're searching for a response. Okay, let us ask Nikita or Vinod. Nikita, after that Vinod.
Sir, depending upon the cause, sir, if it is a fatty scenario, we'll see a fatty liver disease like increased echogenicity. If it is because of the cirrhosis and alcoholic causes, we'll see the nodules and the um,
What is the size of
pattern.
the nodule which ultrasound can pick up?
Not sure, sir. Not sure about the size.
Vinod,
Not sure of size, sir.
Hello, sir.
what is the size of the liver nodule that ultrasound will pick up?
Sir, more than 5 mm, sir.
More than 5 mm, but maybe the newer ones may be even better, but still I think ballpark figure is 5 mm.
Yes.
So basically you are looking at, as Nikita said, various etiology, fatty change, and I think the newer ultrasound will be what is called as contrast enhanced ultrasound scans. Maybe will be characterizing it better. I think Praveen, you still had 15 minutes. If you had explored the possibility of talking about these things, you could have gone and spoken to the radiologist, talk to them about what are the ultrasound features, or then what are spoken to Dr. Vijay Kumar about the fibroscan grade 1, grade 2, grade 3, grade 4. I think there are. What is the significance of that? In whom do you start treatment? Whom do you start thinking about transplantation? And then MR. I think MR also will give you the MR is also very good in telling us about the how good is the liver, whether it is fibrous or is it still supple. I think MR better than CT for that. So all of these things, you should have been able to speak about. Still had time. See, this is you need to start thinking like postgraduates rather than just undergraduates looking at some textbook or some one article and then coming and talking about it. MELD score significance. Child Pew, you have not put up the all the scores. Just put up some random one. There is a Child Pew, each of what level of albumin will be, what level of prothrombin time. I think all of those things are important. No, you're talking about cirrhosis and liver disease, and I think those figures are extremely important because we should know when we should refer these patients, not just the score but individual values also. I would say, I think Niranjan, I'll leave the final this one to Niranjan. I would say this was it's a vast topic, I agree, but very poor effort in, I think postgraduate level, this one, it was very haphazard, not well organized. I think basically what you should do is to first list out the causes, then talk about the pathogenesis and pathophysiology, then talk about the investigations, blood and radiology, then talk about the treatment, as Niranjan said. That is the pattern that you should have followed. There is a lot of mishmash. I don't know, generally you are good, but today you was very disappointing. What, let us ask.
Agree.
Let us ask the
Agree.
postgraduates and Niranjan will final comment.
Yes, sir.
Postgraduates, what did you feel? Hello? Vinod?
Hello, sir.
Ah,
That's what, sir. Maybe you would have told me how the first investigations and then each disease separately.
I didn't follow you.
First of all, if a patient comes with a chronic liver disease, then I have to investigate and then I have to diagnose each what is a particular cause, and then you would have told each disease separately. That would have a better ideas.
Nikita?
Sir, recent advances have, I think they were missing, sir. They were need to be put up, and I think we'll read up about it and put it in the group, sir. Yes.
Tanya?
Sir,
Hello?
I thought, hello, so can you hear?
Yeah.
I thought it would have been more elaborated, sir, like you said. It is a very vast topic, lot of things to cover in this, which everybody has to know. So
Yeah.
some more information would have been there.
No, not just in a lot of information, but more, in a more organized and classified manner rather than
Yes,
just
sir.
splitting from one to another.
Yes, sir.
Niranjan, final thoughts, I think.
Sir, that is what I agree with your whatever you said. So it should have been more organized, and I felt probably got confused because there was too many topics, and each individual topic can be a single class, like portal hypertension, alcoholic liver disease, and viral hepatitis. So probably he got confused there, and the organization was not there. He probably got confused, and since it was part of a different class where he wanted to fit it everything in 45 minutes or 1 hour, so probably he was not prepared for this separate individual class. So, anyways, Praveen, you can improve. So you can whatever questions you have asked, all of you can put it up in the group.
Praveen, it is not to discourage you. I think it is, we are all, for example, say I stood corrected about this autosomal recessive dominant. I think we all can and should make mistakes so that we'll learn from them. So I think it is for you to understand, how to, for example, plan a presentation, especially of this nature. Because I think this is a medical topic, but you have to talk about the surgical relevance of this. So that is where this child Q scoring, MELD scoring, because liver transplantation is a surgical topic. So I know we will talk about liver transplantation. That will be more of a technical talk about the technique of liver transplant. Here you have to talk about the indication separately. Okay, good.
Yes.
Okay, thank you, sir. I think we'll end it. Yeah, thank you. Good night.